Good day. My name is Paul Wax. I'm the Executive Director of the American College of Medical Toxicology, and I'd like to welcome you to our webinar series, The Medical and Public Health Considerations of COVID-19. Today's session will include a talk on the EMS operations in cardiac arrest and also an update from the front lines from Brazil. Next slide. I'd like to thank our webinar series partners. Next slide. I'd like to remind everyone that this webinar is being recorded and will be posted to the ACMT website, usually within 48 hours. Information about this webinar series and our website can be found at acmt.net/COVID-19 and any questions about the webinar series to be sent to info@acmt.net. Next slide. These webinars typically feature a spirited Q&A session at the end. I invite folks to chat in questions either using the chat function on the WebEx or the Q&A function. For those of you on YouTube or Facebook, you can also use the chat function to chat in questions. Next slide. At this time, I'd like to turn the presentation over to my co-moderator, Dr. Ziad Kazi. Dr. Kazi is a board member of the American College of Medical Toxicology and president of the Middle Eastern North African Clinical Toxicology Association and an associate professor of emergency medicine at Emory University. Dr. Kazi.
Thank you, Dr. Wax. It's my pleasure to introduce our first two speakers that will be presenting the didactic part of our webinar today. It is essential to include our colleagues in the emergency medical services community in the pre-hospital area of the response to this unprecedented disaster that we are going through over the past several months. So it's our pleasure to address this topic today with two experts in this area, Drs. Bryan McNally and Lekshmi Kumar. Dr. McNally is a professor of emergency medicine at Emory University School of Medicine in Atlanta, Georgia. He's also the principal investigator of the CARES registry that he will share some very interesting data about during his presentation. Dr. Kumar is an associate professor of emergency medicine at Emory University and is the current medical director of the Grady Emergency Medical Services, which is the largest EMS provider in the state of Georgia. Dr. Kumar will tackle the important aspects of operations during this pandemic and some of the tools that they've used to protect the responders and make their response very efficacious. With that, I will turn it over to Dr. McNally. Thank you.
Thank you, Kazi. I appreciate the opportunity to present today with Lekshmi, and I'm going to present a little bit about an outline here of the talk today. Obviously focusing on out-of-hospital cardiac arrest, but a lot of the same themes would apply in hospital. I know a number of listeners are both from EMS as well as hospital sides, so it's really focused on first about optimizing out-of-hospital cardiac arrest care. Talk a little bit about CARES, like Kazi mentioned. CARES stands for the Cardiac Arrest Registry and Enhanced Survival, specifically looking at some more recent preliminary COVID data for the last few months. Lekshmi will talk more about the importance of obviously good communication in this COVID times between EMS and the hospital, medical control. We'll talk a little bit about non-ROSC, and for ROSC I mean return of spontaneous circulation, patients that obtain a pulse post-cardiac arrest, and those that would benefit that are non-ROSC from transport to the hospital. We'll talk a little bit about termination resuscitation guidelines, and obviously minimizing the transport of medically fetal patients. CARES, as I mentioned earlier, is a registry that collects cardiac arrest outcomes that's been around since 2004. The focus is standardized outcome measures to do quality improvement at the community level. You can see here on the slide showing a footprint where you see green are actually, we have a state coordinator, where you see individual cities. We have participants. The current participation is about 45% of the country, almost a catchment area of over 144 million. The registry has grown a year. This past year, which you don't see on the graph, there are 100,000 patients that are entered, non-traumatic cardiac arrest patients, over 1,000 hospitals. So the value of having this footprint is a better understanding of what's been going on more recently. Yes.
I think your audio is choppy. Would you like to switch to the phone?
I'm on the phone right now.
Okay.
Can you hear me okay now? Yeah, and I apologize. So when we talk about out-of-hospital cardiac arrest survival, two things to remember are patients that have a witnessed event that present a shock or rhythm have a much more favorable survival, about a third. We look at all cases, regardless of rhythm and regardless of witness status, is about 10%. Bystander CPR by itself can double or triple survival. But the greatest predictor of survival in the field is obtaining ROSC or pulse. You have a 35 times greater chance of survival than a patient that is non-ROSC in the field that's transported to the hospital. So arguably, care in the field really often determines whether the patient survives or not. Obviously, hospital care is important, but it doesn't take away for a failed resuscitation. Here really, this is data from 2004, Canadian OPALS trial, which really shows the importance of the links in the chain of survival. And obviously, the community links are really important. Early access to care, a bystander recognizing and calling 911 can almost quadruple survival compared to a delayed interaction. Early bystander CPR, as well as early defibrillation. But these early links in the chain of survival that are, again, community-centric, often can have a great impact on the care in advance of EMS arriving. ALS care, as you can see here, does not have the same impact. Doesn't mean that it's not important, but has not been shown to have the same influence as those initial links. This is a more recent trial. For those who may be familiar, this is New England Journal Paramedic 2 trial. This is UK-based study that looked at administration in the out-of-hospital setting of epinephrine. The study basically concluded that there was a slight increase in survival in the group that got epinephrine compared to placebo. However, they had worse neurological outcomes. The more important aspect of this trial focused on number needed to treat. You would need to treat 112 patients with epinephrine to have one additional survivor, but you'd only need to treat 1 in 11 patients for early recognition, 1 in 15 for bystander CPR, only treat 5 patients for early defibrillation. So you can see, again, those early links in the chain of survival are the most impactful when we look at care in the field. This is data from CARES recognizing when we have patients that not obtain ROSC in advance, the arrest occurring in advance of EMS arrival, the mortality is significantly high. Very few patients survive to discharge that are transported that do not obtain ROSC in the field. The termination rate in the field varies by community. Some communities we know will only transport a patient if they obtain pulse or ROSC in the field. Other communities transport almost every patient. Locally, this is data we looked at our agencies more recently, about 9 to 22%. And the reason it's important is to recognize, if a patient is not obtaining ROSC, and there's conversation between physician and medical control, there's often local protocols in place to terminate resuscitation in the field, and obviously not bring a patient that's not going to benefit from care in the hospital. Obviously, in the age of COVID, there's concerns about risk, exposing that patient to other providers, additional decontamination, et cetera. So it's really important to understand, what is your termination rate in the field, and are you following best practices? So we'll talk specifically about data for coronavirus using CARES data. And first, I wanted to mention, and Lexi's going to talk more about this in detail, in terms of operational changes that obviously needed to be put in place very quickly from both the pre-hospital side and the hospital side. This was recommendations that the American Heart Association came out with specific to resuscitation and COVID. Obviously, the need for appropriate PPE, which I think we're aware of, minimizing the number of providers that come into contact with the patient during resuscitation. Obviously, something that we're not familiar with in years past, and past practice has been often having extra providers. Now it's trying to minimize. Next slide here, really emphasizing prioritization of oxygenation and ventilation, of course, is important, but at the same time trying to develop strategies to minimize aerosolization aerosolization of particles. Obviously, that could include COVID, using a HEPA filter, early intubation, or early supraglottic airway, and obviously looking at the appropriateness for resuscitation, goals of care, as we would in any resuscitation. So this is looking at data, again, limited from February to April of this year compared to the same time frame last year for the etiology of arrests. We see that there may be a little bit, the type there is a little bit small, but overall cardiac arrest etiology is the most common etiology that's presumed. There's been a slight decrease from last year to this year. A slight increase in the number of respiratory arrests have been documented, increase as well as the number of overdoses, and then also an increase in the percentage of cases that are coded as other. And you can see here, part of the other etiology that we allow for, we have a free text box. We added a field back in February based upon concerns about COVID to be able to add COVID as a potential presumed etiology. There were no cases that were recorded in February when we added it, but as you can see in March and April, there was a slight uptick in terms of, this is the field provider saying, I believe this patient was documented to have COVID and we think the arrest was related to COVID-19. Obviously, presumption. What I'm going to show you in the next few slides is actually trend data over the same time period from February through April, looking at the aggregate data. This is about 8,000 patients per month. And you can see that there's a downward trend in the presenting rhythm, shockable rhythm, which is obviously a more favorable scenario. And there's not a lot of reasons we believe this may be true. There may be more delay, obviously, in getting the ambulance crew to the patient if they're putting on PPE after they arrive. There may also be delay in patients activating 911. We look at the percentage of publication arrests that's gone down as well over the same time frame. Again, more people being inside. This is not surprising. We look at the application of bystander AD, application in a public location has gone down. Again, these devices are often in gyms, airports, transport locations where less people are being found, during the age of COVID. So again, a trend that makes sense. Bystander CPR rates has remained steady. When we teased out bystander CPR in the home, there's a slight uptick, and bystander CPR in a public location has gone down. Field termination rate, as I mentioned earlier, this has trended up, gone up by more than 10%. So that, and you kind of put it together, you can see termination rate increasing on the top, CPR again remaining steady, and then everything else downtrending in that time frame. So we're going to be doing a more robust study of looking at data from last year compared to this year and actually link it at county level with COVID data to see whether there are other trends that we'll tease out. I'm going to end there. And again, I wanted to give the big picture of this is close to real-time data as we have at the national level. But I think more importantly is to get Dr. Kumar's perspective on how operational changes have had to take place from her perspective as a medical director of Grady EMS. So I'm going to stop there and turn it over to her. Lakshmi.
Hey, can you hear me okay?
Yes, Dr. Kumar.
Okay, perfect. Thank you so much for the opportunity. And Dr. McNally kind of gave us a big picture at a national level, and I was going to present what we're seeing at an institution level at Grady EMS. So we are a large urban EMS system, and I just wanted to kind of describe what changes we made in our system to respond to cardiac arrest during COVID, how it ties into the national data, and what changes we are likely going to hold on to in the future, whether we're going to keep these changes and some of which we're not, and some of which we actually think may be beneficial. Cardiac arrest guidelines, they may change between, and they may vary between EMS systems because everybody's trying to adapt to the dynamic changes and findings of COVID. And while there's no perfect one solution out there, we wanted to give you our institutional experience to give you a perspective. So Grady EMS is a large hospital-based system, EMS system in Atlanta, and we are a component of the Grady Health System, which is a county hospital. And we serve the city of Atlanta as well as 16 counties across the state. Our annual call volume, just within the city is approximately 130,000. So we are a fairly large service. So when we started seeing cases in Atlanta, we immediately switched on our EIDS tool. So like I said, if we think about this along the chain of survival, the first link is 911 or dispatch. The first cases started popping up. We switched on the EIDS tool, which is essentially a screening tool for patients with influenza-like illness so that we can be prepared when we go into their house. Once the pandemic was declared, we started using our dispatch card 36, which is essentially used to manage triage. And we were able to kind of limit our EMS response in the event of an official pandemic and outbreak, and was used as a surveillance tool to track symptoms and decide whether we needed to change our response. As the cases went up, our concern was, especially with cardiac arrest, everybody could be infected. We didn't know who was infected and who was not, and there was no good way of screening and saying some of them were higher risk than others. This is a graph looking at our cardiac arrest. We really did not see a huge change from year to year. I know some cities saw a huge spike in the number of cardiac arrests. When we looked at our data between 2018, 19, and 20 for the same time period, we didn't see a massive spike. But what we did see was that our public setting cardiac arrests were going down a little bit, whereas our in-home cardiac arrests were going up. And this is probably because of the shutdown and everybody was scared to get out, everybody was in their house. And Bryan already talked about the fact that there is definitely a higher chance of survival if you get bystander CPR, and a lot of people, when they arrest in the house, they are not able to access an AED and may or may not get bystander CPR immediately. So this was a change that we saw with our data. So like he mentioned, we decided early on that we are going to consider every cardiac arrest as possible COVID patient, just given the high risk. And we immediately mandated that the least number of personnel that are required should be on scene working with the patient and everybody else who is on scene, because for us, every cardiac arrest, usually we have a fire first responder service as well as an EMS unit that comes on. And we said only the least number of people should access the patient. Everybody else should stand 6 to 8 feet away from the patient. We insisted that they don their PPE before entering the scene, because a lot of times people go in and they're like, we will put it on, and adrenaline, there's a cardiac arrest, they go in and they forget PPE. So we required them to actually don PPE before they even hit the address that they were supposed to go to. For us, PPE, we had a single pair of gloves, and we were asking them to change their gloves if there was any issues with that. We asked them to put on a disposable isolation gown, and all cardiac arrest patients, we did require them to have an N95 on, along with eye protection and or a shield that fully covers the front and sides of the face. Now, with this, as time went on, we did have supply issues with our N95, and we were reusing the N95, and we required them to have a surgical mask covering it just to make sure that they weren't soiling the N95. We ran into issues with the isolation gown. We ran out of supplies fairly quick, and we had to replace it with Tyvek gowns, Tyvek suits instead, just because we couldn't get gowns in a timely fashion. So we did talk about airway management. The guidelines say early intubation. We, as a service, we do not have video laryngoscopy, and we are not able to, our paramedics are able to intubate, but because they did not have access to video laryngoscopy in the field, we decided to go with an iGel or supraglottic airway up front. To control the airway until they can get them to a hospital if they do, and the intubation can be performed there. Just given the risk of COVID, and without the luxury of having video laryngoscopy and the concern that they might not get the intubation in first pass, we decided the iGel was a safer option. HEPA filter use was recommended. We did try to immediately order a bunch of HEPA filters to kind of outfit every single ambulance, but of course they were on back order. And we ended up getting the J circuit filters, which work the same. They're slightly different. And we have outfitted the ambulance with these for all our iGel use. And I think Bryan would agree this is probably the most important slide of all when we get to resuscitation, staying in place to provide high quality CPR. So our medics, once they get on scene, they initiate CPR, and at some point they start transporting, but we insisted that rather than picking up the patient, putting them in the back of an ambulance and immediately transport to the hospital, we want you to stay there, provide high quality CPR to give the patient the best odds of ROSC and minimize the amount of transmission of COVID. So they would stay in scene to provide high quality CPR for all cardiac arrests until they got either ROSC or asystole. If the patient had sustained asystole, then they could call medical control for on-scene termination. As there was really no chance of getting ROSC, they would just terminate on scene, decreasing the risk of medics getting COVID by transporting a patient with active CPR and airway management, and decrease the exposure to the hospital staff as well. So we had a robust online medical control involved with the whole process to assess and decide if this patient could be terminated on scene. So we have certain cessation criteria, and of course these are guidelines. The patient had to be an adult patient above 18 years of age. They were not getting any ROSC despite staying and doing CPR in place. They remained in asystole or PEA, and they were able to adequately ventilate the patient during the time, and they were able to get access with an IV or an IO and provide all the ACLS medication. They were not hypothermic, which is really not an issue in Georgia, especially at this time. And this was a non-traumatic cardiac arrest, so a medical cardiac arrest, and that the medic had actually considered all the reversible causes. And whenever a patient had to, like, a medic had to perform cessation on scene, they would call med control. And the role of the physician in the hospital would be to talk to them and kind of run through the reversible causes, make sure they met all the criteria before they decided that they were going to terminate the arrest on scene. There were, of course, special situations. Pediatrics, it depended on the age, depended on what the scene looked like. There were some times that we would stop on scene versus having to transport. Witnessed arrests were always a challenge because we've seen that early defibrillation, early CPR has a higher chance of ROSC. So witness arrests automatically had a higher chance, and they weren't down for a long time. But we would stay and do active CPR, wait for a good while, and then discuss with the physician if this was appropriate for scene termination or not. If they had a persistent shockable rhythm, multiple shocks, and they were still in refib, we usually ended up transporting the patient to the hospital. And a lot of public arrests, so this was a challenging one. If this was a public arrest, for multiple concerns other than medical, as in scene safety, whether it was safe to leave, if we did end up not getting lost and we decided to terminate, was the scene an appropriate scene to terminate? Were they in a public lobby of a hotel? Were they in the middle of the street? Was it an airport? So a lot of the public arrests, unfortunately, have to be transported just for various other situational causes. But these were all special situations that we discussed with the physician and made sure that everybody was aware of what was going on. When we got to the hospital, we changed our approach to the hospital a little different. So before, we would just take the patient right into the ER and put them in the critical care bay. But we would call call ahead, and we would be met at a little decon room between the ER and the ambulance bay so that the patient could be wheeled in there, and that was still considered a not clean zone. And maybe the physician and one provider would come out, assess the patient, kind of get report, and make sure the rest of the staff were ready, and if and had their PPE on, and if the patient warranted continued resuscitation, they would take them into the ER for continued resuscitation. And if the patient was public arrest or there really wasn't any role for continued resuscitation or it was going to be terminated, they would just terminate in that room itself so they didn't expose the rest of the ER and the rest of the personnel to the patient. There are some centers actually that are where public health was testing the cardiac arrest patients after termination to see if they had COVID, but we have not been doing that in our city, so it's very hard for us to say what percentage of our cardiac arrest was secondary to COVID or not. But this is something that would be interesting to obtain because it's always challenging to know. So that's kind of our institutional perspective. The future guideline changes, so I think, of course, limiting and having full PPE on every cardiac arrest is probably not going to hold once COVID is, once and hopefully when COVID is. And airway, of course, we would eventually go back to intubation. But I think the whole concept of staying on scene, providing high quality CPR, and transporting just the patients that have higher chance of ROSC or obtain ROSC, that is something that we are probably going to hold on to even in the future. I think that's about all I had, Dr. Kazi.
Thank you so much, Dr. Kumar, Dr. McNally. That was a very interesting overview of data from the CARES registry that certainly warrants more discussion and thinking and research, as well as the operational challenges and solutions that you've presented. Those are also certainly to be learned from for future emergencies that we are undoubtedly will encounter in the future. Please type in your questions in the Q&A or the chat. We already have several questions in the pipeline, but we'd like to receive some more, and then while we present the next topic with our speaker from Brazil. This is the update from the front lines, Sao Paulo, Brazil, by Dr. Alvaro Pulchinelli. Dr. Pulchinelli is a clinical psychologist and clinical pathologist and a field professor at the Federal University of Sao Paulo. Dr. Pulchinelli is also a medical supervisor at Planetox and a medical advisor at Fleury Laboratory, Scientific Director of the Brazilian Society of Clinical Pathology. Dr. Pulchinelli, thank you so much for joining us from Brazil, and we are looking forward to your update.
Oh, thank you for inviting me and the opportunity to talk about the situation in my country. In my country, you have a perfect storm. Here, where the four horsemen of the apocalypse. We have the pandemic, the fragility of our health system, the vanity and the ignorance and unfortunately in your country. The first is a pandemic. As we know, the behavior is now the pandemic situation. We are, unfortunately, the second country in number of cases. Nowadays, we are the epicenter of the pandemic. Next. The fragility of our health system. We are 220 million inhabitants with great social inequality. Our private health system covers only 25% of the population, but by the Brazilian Constitution, the public health system must be covered 100% of the population. 5% of the population prefers the access to the private system, but they have access in both systems. The spread of the disease causes concern about the health system. We see best private hospitals are under constant concern with the prospect of not being able to meet the demand. The private hospitals, the big private hospitals in Brazil, it's so worried to try to treat our demand. The public hospitals have an average occupation rate of 19%. In my state, São Paulo, the average rate is about 75%, 80%. But there are places and the system has collapsed. The state of Amazonas, Fortaleza, and Rio de Janeiro. Next, please. The third problem, the third horseman, it's a great vanity. Vanity of politicians and the medical profession. Our president, unfortunately, with an attitude that denies the magnitude of the problem, does not fulfill his role as a leader and attacks the governors. And today it's released a text in New York Times talking about this. On the other side, governors counterattack. However, governors don't have an unfiled proposal. So it's a internal war, president against the governors and the population and the media. There's a large underreporting of cases. The system of information in Brazil is very poor. And nowadays, the president attacks the system too. He tried to control the numbers artificially. The numbers of tests is still low. This scenario is changing. Next weeks, we have a great providers, a great industries from laboratory kits is coming to Brazil with your products like Roche, Abbott, and Thermo Fisher, and so on. So this the number of tests will be raised in the next days. Finally, the doctors are also lost in useless discussions. We have never had so many scientists and experts in COVID-19, and we never been so poor information. In doctors make much noise but no information. Next. Yeah, and fourth, our ignorance. Results of a low educational level of our population. Part of the population simply does not meet the isolation norms because the factors of non-compliance are denialist attitude, like our president, ignorance of the danger of the disease, and no have financial resources to remain in isolation. Our population is poor, don't have money to comply with the quarantine. And from the toxicological point of view, we see increasing cases of poison by household cleaning products. The Anvisa, our FDA in Brazil, released this week a report talking about this. So, the next. In the Brazilian Society of Clinical Pathology carries out a project with the aim of testing the diagnostic tests used in our country. The results are in this website. The website has a version in Portuguese, Spanish, and the next week the version in English version. Next. Oh, it's all. Thank you for opportunity. This is my contact forms, and it's all. Thank you.
Thank you very much, Ms. Paul Wax, and I'd like to thank Dr. Pulchinelli as well as Drs. McNally and Kumar for really excellent presentations. We have a number of questions in the Q&A and the chat function. For those who have not yet put in your questions, please put them in now, and we should have plenty of time to go over the questions over the next few minutes. I'd like to start off with the first question, which was addressed by the second speaker a bit toward the end. But in terms of the sustainability of the change in practice regarding field termination, could you elaborate perhaps a little bit more about whether there had been any movement in that direction, pre-COVID, and what long-term benefits might appear from the change in practice long-term?
So we were actually thinking about some of these changes even pre-COVID, as in we were redesigning our field termination guidelines and expanding our inclusion criteria, but we haven't, COVID just kind of put their foot in the accelerator for that. And I think with all the data that Dr. McNally has presented, there is good evidence to show that there are certain groups of patients that will benefit from transport, whereas there are certain other groups that, transport is going to be futile just because their ROSC chances are so slim to none. I think going forward, our field termination guidelines would probably stay the same way, where we continue to stay and resuscitate and transport just the patients that have a higher chance of survival versus, of course, all the caveats that we mentioned.
Yeah, and I can add to that. I think that's a great answer. Like Lekshmi said, showing that upward trend, we know there's been significant changes. Most agencies have protocols in place and have for years. The variability in how they follow them, I think, is being looked at more carefully. I think people recognized overnight, this patient that may have a very low chance of survival that's being now sent to the hospital is being looked at very differently than just a few months ago because of the downstream impact, the risk to providers. Things that you don't think of, but you realize now you're going to spend an hour cleaning and decontaminating an ambulance, an ER room for more than an hour, extra PPE, but it really comes back to, it's about medical futility, and that's really that hasn't changed. It's looking at how you're applying the protocol in your own system and looking at, are you, some systems, like I said, they transport 100% of patients regardless of their ROS status. In other systems, pre-COVID, religiously, were not transporting patients unless they got, a pulse back with exceptions. So I think that variability is going to narrow because more communities are looking at their transport policies.
Okay, great. Well, thank you. Do you have any experience, particularly through your paramedics, about the acceptance of these sorts of decisions in the field by families and other bystanders?
So I saw one of those questions on the Q&A box as well, and field termination has always been part of our guidelines. So it was, we just expanded the inclusion and kind of emphasized it during COVID. It was not met with resistance from our medics at all. And of course, there are certain situations where the family is uncomfortable about it, or there are fire personnel there who are uncomfortable about it, or PD is uncomfortable about it. It's in a public place. When they call the physician, and if it's something we are able to talk to the family or we are able to explain stuff and actually follow guidelines, that's great. But my stance and the agency stance has always been, if you feel uncomfortable about it and it's not safe to call it in the field, then don't, terminate in the field and just transport. And that would be one of those special circumstances. But we haven't had, thankfully, too much pushback.
Yeah. I think just like managing a patient in our own emergency department, and making a decision about when to end the resuscitation, just like in the field, there's a quantitative and a qualitative side to that, meaning you've got data in front of you, how long the resuscitation's gone on, whether you got Ross back, whether they were ever shocked, the circumstances before that patient arrived in your department, and then the qualitative, particularly in the pre-hospital field, what is the family's reaction? Obviously, a witness arrest where the family's involved, you're much more likely going to be bringing that patient to the hospital if it's not acceptable. If it's in public view, like Lekshmi mentioned, the patient's not going to be left there. So it's always going to be a conversation, but trying to look at the vast majority of these events year to year are going to occur in the home. More than half of them are going to be unwitnessed. Most are going to present an unshockable rhythm. And with initial resuscitative efforts, a very large percentage are not going to obtain ROSC. The question really comes down to, at that point, you should be engaging with medical control and having a quantitative and qualitative conversation, making sure that it's acceptable. Every patient being treated, of course, individually, but looking at, communities that are transporting 100% of their patients are probably not invested in practicing evidence-based medicine. Communities that are only transporting tour patients are more likely a well-developed system that's thought through these issues more carefully. I think COVID has just accelerated the process of protocols that have been in place, but actually looking at are we having those conversations regularly? Are those decisions being made appropriately?
Okay, great. Thank you. Another question is about bystander CPR, and if a bystander comes upon someone who's arrested, the COVID status is unclear, what should they do in terms of initiating CPR and making any sort of variations from the standard protocol? And you may just want to comment just about the changes in CPR over the years in terms of mouth-to-mouth resuscitation as part of that.
Yep, I started to type a response, but I had too much to say, so I'll try to say it quickly. It's a great question. I think the answer is you assume the patient has it. So in adults, where you have one provider, compression-only CPR, unless you believe it's a respiratory arrest, is really considered the standard of care. So minimizing ventilations. There's some discussion about the guidelines that came out about covering the person's face. If you have a mask, you should wear a mask to try to minimize your exposure. But compression-only CPR for an adult. For children, the recommendation, if the provider is willing to do it, is compressions and ventilations, because these events are more likely a respiratory etiology. Most of those events, tragically, will occur in the home. So often it's going to be a family member that's more likely to initiate if they're directed by the dispatcher, if they're not already doing CPR, to do ventilations and compressions. If it's two providers and you have a face mask, obviously using that, and yourselves wearing masks. So trying to minimize your exposure, but compression only in adults and conventional CPR in children is a recommendation.
Okay, great. Thank you. Now that the weather is warming up towards summer, have you seen any signs of relaxation of PPE use and other precautions, just due to the warmer weather?
Yeah, we've definitely seen PPE fatigue, where providers are becoming a little more lax, and we've had to send out reminders and kind of remind them during shift huddles, just to make sure that they remember that this is also going on. And I mean, with all the other stuff that's politically happening as well, sometimes the focus also shifts and they forget. So it's one of those constant reminders that we've had to do. But I definitely noticed that, because we're doing this day in and day out, there is a certain amount of PPE.
Okay, great. Thank you. And speaking of, the last several weeks and the other crisis with, protesters and some rioting early on, and I know there was some of that in Atlanta as well. Are there any changes in terms of doing it at the scene versus scooping up the patient and moving to the hospital because of the compounding issues of the demonstrations at the scene?
So I can kind of go through what our policy is with everything that's happening. I mean, thankfully, the last few days, everything has been peaceful, but there were the initial 1 or 2 days where it was a little more violent. And we have always maintained safety as our first priority. And for the most part, we are kind of positioned and staged right outside the hot zone. And we have patients brought out from the hot zone to us for further medical care. Thankfully, we have not had any cardiac arrest within the hot zone. Most of the calls that we received were all minor injuries or 1 or 2 not minor trauma, but have not had cardiac arrest rolled into that, thankfully.
Okay, great, thank you. I think I'll turn it over to Dr. Kazi for a few additional questions at this point.
Thanks, Dr. Wax. Great Q&A so far. Just wanted to add a couple of questions to Lekshmi and Bryan, and then turn it over to Dr. Alvaro. So actually, we have a question from Iraq. Just to remind us that we have an international audience for our webinar series. One of our colleagues, emergency physicians from Baghdad, is asking about what's the data behind hazards and risks to the EMS provider while performing CPR on a COVID-19 patients. Are there anecdotal evidence of exposure and infection of a pre-hospital provider after this type of activity?
I can go first, and Lekshmi, please jump in. I don't think there's data. I think the data that I think is useful locally in our own healthcare system is looking at the positive antibody rate. I think it's more than 4,000 providers have been tested in our healthcare system, and it's under a 4% antibody rate. And obviously, some of those may be false positives. Others are likely community-based. So to me, it tells me in our healthcare system that thankfully was not overwhelmed, that doing standard PPE seems to be working. We're not seeing higher rates like in Italy or New York City, where there was a much greater number of providers, healthcare providers, that were becoming infected. And I think now that the dust is sort of settled and COVID has been around for a while, we believe it's likely when a system is overwhelmed, that's when you're at much greater risk. When a system is thankfully not as taxed, standard PPE, meaning in our case an N95, a gown, a mask. If you're doing invasive procedures, making sure that you're shielding and you're minimizing your time. We have a protocol for trying not to use non-invasive ventilation because we think it's too high a risk with aerosolization. So though we don't have data, the data I have locally reassures me that in a system that's not been overwhelmed, standard practice seems to be working. Other communities that are impacted greater, there's probably greater risk to provider.
And then Lekshmi, can you share some more information about any occupational monitoring programs you have, or is there any? Are you doing that for the paramedics?
Yeah, so we are actually screening them, and they're supposed to check their temps at home and make sure they don't have any symptoms prior to coming to work every day. And it's mostly a self-reporting to the same institutional occupational health that would further assess them for risk and decide if they warrant testing, if they warrant staying off of work that day for a shift. The interesting thing, for the medics, it was very similar to what we did in the hospitals. The other interesting group within our EMS system that I had to think about was the dispatchers, because they're all sitting in the dispatch center and answering calls. There was no way they could do that from home for sure. They had to be in the dispatch center. We had to do some geographical turning around and positioning so that they were 6 feet apart, or more than 6 feet apart. And we provided them masks, which was also something we had to think about, because sometimes when you're answering calls, the mask itself can kind of muffle your voice a little bit. And we had all the concerning influenza-like illness symptoms, as well as a reminder to check their temperature stuck on the door of the dispatch center, so that when they walked in and clocked in, they were able to go through the list and make sure they didn't have anything before they came to work.
Very good. And I think, Bryan, you mentioned the decontamination of ambulances. Can you just maybe provide some more information about that process?
I'm gonna bet you Lekshmi is more an expert than I am. My understanding was, when there was an active, resuscitation came in, and there was a basic procedure done in the ambulance, like intubation or CPR. Besides cleaning it, there would have to be an hour sort of period in time where the ambulance cleared of COVID, so to speak. On the receiving end, we had the same protocol early on. I think it's since changed, but that a room would basically be out of service for an hour after it was cleaned. So, Lekshmi, am I correct in that assessment about the ambulance, that it was out of service for a period of time?
Well, so we actually had, if we had a high procedure or a concern for a COVID patient, and this is initially, like when we were not seeing as many, we would have the ambulance come back and do a deep decon, and because of that, they would be grounded for an hour. But as we started seeing more cases and there were more people that fell within the influenza-like illness and possible COVID category, we started, using the wipes and doing a regular decon that we would do, just a thorough decon, and we would come back for a deep decon only for the aerosolizing procedures, and which was much, much less, because at some point we said we're not going to do aerosolizing procedures in the back of the truck.
Thank you. I'm going to have 3 more questions for EMS, and I have a couple of questions for Dr. Alvaro. This came through in the chat box. One of them is, can you please tell us more about what is quality CPR? That's number 1. Number 2 is, can you please repeat again what you talked about, the cessation criteria? Thank you. So that maybe.
What is quality CPR?
Yeah, that was the question. What do you mean by quality CPR? And then what is the, and then can you please repeat the cessation criteria?
Yeah, I go first, and I know Lex, we can jump in. I think from a medical provider, EMS provider perspective, quality CPR would be following guidelines, minimizing interruptions, correct depth, correct rate. Some systems obviously use mechanical CPR devices, not so much locally with great EMS, but the idea is that you're performing minimally interrupted compressions. What we call your compression fraction is 80% or greater. If you have the opportunity to do QA on the case, that would help you with recognizing you're actually following guidelines. So that would be maybe a short way to say you're doing quality CPR from an EMS perspective.
Thank you. And
you agree with that, Lekshmi?
And yeah, cessation criteria, we can, if you guys want to go back and hold the slide up for a bit, they can look at it, but essentially we chose adult patients that had no ROSC and remained in asystole or PEA despite high quality CPR for 20 minutes. And we were able to, during that time, to adequately ventilate. We had IV or IO access established, and we had administered ACLS medication during this time, that they were not hypothermic, and it was not a traumatic arrest, and we had actually considered all the reversible causes of the arrest.
Thank you so much. That's great. And then a question, Dr. McNally, about the CARES data and the overdose. We are very interested in overdose as well. Are you able to get more granular and on this type of data, or this is all you can get?
Sure, and I'm happy to talk with you offline as well. We do have, the more granular data, which I'm not presenting today, is by age group. We put out an annual report, and I can tell you, age 18 to 35, there's almost as many patients presenting with a suspected overdose etiology arrest as they are with cardiac etiology. Younger age group, we think less cardiac etiology. So it's clearly there's a subset of patients in that demographic, that being the greatest. It trails as you get older. There's less patients that are being presumed to have opioid related. But even in the pediatric set under 18, we have several, particularly teenagers. So we have more granular data by age group and obviously by geographic location. Certain states in the Northeast, almost 25% of the cases that they're entering into CARES, where there's active resuscitation, they believe it to be a presumed overdose related. We obviously don't know. It's up to the crew We don't do toxicology, of course, on the patient in the field, but if they have a needle on their arm, if there's paraphernalia, if there's a history that goes along with it. So we believe that EMS is using the clues around them to make that determination, but up to a quarter of the patients in certain states. So it's there's definitely more granular data, and it's definitely regional as well.
Very good. Thank you, Dr. McNally. Thank you, Dr. Kumar. Dr. Alvaro, saving you some questions here at the end of our webinar today. Thank you for your patience and waiting. I have a couple of questions for you. One of them is related to the epidemic curve in Brazil, and how currently Brazil is experiencing, as you described, being an epicenter of the pandemic. Can you maybe elaborate on why you think that is, and also can you also talk about some of the temperature, climate effects on transmission? I know Brazil is on a warmer climate. Can you maybe elaborate on that as well?
And the curve in Brazil is still rising. It's an incredible velocity, and the warming, the temperature in Brazil still warm all the year. It's not, we don't have a great winter or a great summer in the most part of the country. And the south of the country, it's more cold, but it's not very cold. Right? So the temperature today is about 20 degrees Celsius. Right? So we don't believe that any influence of the temperature. By the way, the cities, the warmer cities like Fortaleza, Manaus, and Rio de Janeiro are the epidemic, pandemic, high levels of cases. So, and this is not a significant question. In this week, our health minister talked about this, but words of poor of scientific information.
Thank you. And I guess my last question to you is related to the overall picture. As you and I have been working with our team at ACMT to prepare this webinar, Brazil has been in the media quite a bit, and we were all concerned. And our thoughts and hearts go to you and your countrymen and women. What do you think is the future? What do you think are future solutions or future steps that can help alleviate the burden of this pandemic on Brazil?
Nowadays, the timing, only the timing, because we don't have a schedule, we don't have a health plan. Right? So, we live day by day today in Brazil. So we hope the numbers of cases decrease in the next 2 weeks, but it's only a hope. It's not signs of this. Right? So unfortunately, the quarantine is living in Brazil. With a great number of cases. So we are very, very worried.
Well, please be safe and know that we are all thinking of you and wish you the best and the end of this the surge in your cases. With that, I would like to thank all of our speakers and turn it over to Dr. Paul Wax.
Thank you, Dr. Kazi. And I'd like to thank everyone for their participation in a very active Q&A session today. Next slide, please. Again, this webinar will be posted on the ACMT website by Friday. Feel free to invite your colleagues and friends to visit the website. Website address is at acmt.net/COVID-19 web. And any questions can be addressed to us at info@acmt.net. Next slide. We will be continuing our weekly webinar series next Wednesday on June 17th. We'll have Dr. Jonathan Brash, who's a research nephrologist at Columbia University PNS School of Medicine. He'll be talking about acute kidney injury during COVID-19. And we'll also have a very interesting update from the front lines regarding protesters, tear gas, and COVID-19. That's next Wednesday, June 17th at 3 p.m. Eastern Daylight Time. And an announcement regarding that webinar will be sent out over the next couple of days. Thank you very much and have a good day.